Good afternoon, everyone. Today, my topic of discussion is approach to headache. So, without wasting time, let's start with the topic. Why discussion of headache is important? Because headache patient come to OPD of each and every specialty, and global burden of headache is very high. We see one in every 3 person in this world has severe headache at some stage of their life. And if we see worldwide, almost 40% adult population has headache at least once a year. In our neurology OPD, almost 25% referrals are for headaches, but good thing is majority of headaches are benign headaches. So chief objectives of this talk are to learn about major types of headache, to understand the basic difference between primary and secondary headache, how we can differentiate these secondary headaches from primary headaches, how we should approach a patient of headache in our OPDs or ER, and lastly, treatment and prophylaxis of some of the primary headaches. So first of all, it is important to differentiate between primary and secondary headache. What is primary headache and what is secondary headache? So primary headache is headache when there is no underlying structural or metabolic abnormality in body. Secondary headache when there is some underlying structural abnormality in brain, outside brain, or some metabolic abnormality in the body. Common examples of primary headaches are migraine and tension type headache. How secondary headache arises. I have told that secondary headache is headache which originate due to some structural pathology, like some extracranial structural pathology like sinusitis, otitis media, glaucoma. Intracranial pathology like tumor, abscess, meningitis, dissection can give rise to headache. Some metabolic disorder like CO2 retention, OSA can give rise to headache. Some systemic disorder like accelerated hypertension, viral fever can also cause secondary headaches. So first of all, we will discuss some of the common primary headache, and among primary headache, migraine and tension type are two most common headache. So first we will discuss migraine and what is the diagnostic criteria for migraine. A patient who is having recurrent attacks of headache, and at least 5 attacks should fulfill criteria B to D. And what is this criteria B to D? Headache should last for 4 to 72 hours. Headache should has at least 2 out of these 4 features. It should be unilateral, it should be pulsatile, it should be moderate to severe in intensity, it should be aggravated by routine physical activities, and it should be associated with at least 1 out of these 2, nausea and vomiting, photophobia and phonophobia. And lastly, this headache should not be attributable to other disorder. So migraine headache is very common among society. Almost 15% of general population is affected by migraine, more common in female, and in almost 50% cases family history is positive. Common precipitants for migraine are caffeine, chocolate, alcohol, stress, hormone replacement therapy, etc. So what are the clinical characteristics of migraine? Basically, there are 3 phases of migraine. First is prodrome, second is aura, third is ictus, that is true headache. So prodrome may be non-specific. It usually occurs hours to days before headache in the form of irritability, mood disorder, mood swings, lethargicity, followed by some sort of aura. Most common type of aura is visual aura, in which patient may feel scintillating scotoma, zigzag lines, blurring of images, flashes of light. This aura usually lasts for 5 to 60 minutes, followed by actual headache, that is ictus. Coming to treatment of migraine. Migraine is basically, there are 2 aspects of treatment. One is abortive treatment, basically treatment of acute attack, and second part is prophylaxis of migraine to prevent the occurrence of episodes. So in acute treatment, if patient is having mild episodes, you can use paracetamol or NSAIDs like ibuprofen, naproxen. But in moderate attack, you can use NSAID plus dopamine agonist like napradine, Nexdome. Apart from these, we can use 5-HT1 receptor agonist. These are of 2 types, non-selective and selective. Among selective, we can use sumatriptan, rizatriptan, zolmitriptan, etc. But sometimes patient of migraine present in emergency with severe attacks of headache. In those cases, we can use sumatriptan subcutaneously, or nasal spray of zolmitriptan, or oral strips of rizatriptan. and rarely we use DEXA in single dose. This is basically to abort the acute attack of migraine. So coming to prophylaxis, when patient needs prophylactic treatment for migraine, basically prophylaxis is needed when a patient is having 3 or more than 3 attacks per month, which are causing impairment of his quality of life. What are the common prophylactic agents for migraine? First line agents are beta blocker, tricyclic antidepressants. Second line agents are topiramate, divalproxodium, flunarizine, and other options are SSRI or SNRI. Some special consideration: if migraine patient is having comorbid hypertension, then our choice should be beta blocker. If migraine patient is obese, treatment of choice is topiramate, as this also causes weight loss. If migraine patient has comorbid depression, our treatment of choice should be tricyclic antidepressant, SNRI or SSRI. So coming to common case scenario, classical prototype patients. This 28-year female presented with headache for last 3 years. Headache was intermittent. Frequency was 6 to 8 attacks per month, and each episode starts with flashes of light for few minutes, followed by severe pulsatile headache, which usually lasts for 5 to 6 hours. And if she takes painkillers, this headache subsides early. Headache is usually more on one side, but side may switch. Sometimes it becomes holocranial. And during these headaches, she is not able to carry out her daily routine activities. On examination, there was no neurological deficit and there was no disc edema. So from this presentation, from this clinical picture, it is clear that patient is classically having migraine with visual aura. So in such type of cases, investigations are usually not required. Patient needs abortive treatment as well as prophylactic treatment. Coming to second variety of primary headache, which is very common, that is tension type headache. In this headache, basically patient should have recurrent episodes of headache, and at least 10 episodes should fulfill criteria B to D. And what is this criteria? Headache should last for 30 minutes to 7 days. Sometimes this headache for prolonged period, almost 7 days. Headache should has at least 2 out of these 4 features. Non-pulsatile in character, mild to moderate in intensity, usually bilateral, and this headache is usually not worsened by daily routine activities. And patient should have both of these following 2 features. There should be no nausea, no vomiting. But they may have one of 2, either photophobia or phonophobia. Treatment of tension type headache is very simple. Simple reassurance, relaxation, proper sleep, massage, or sometimes simple painkiller. But if patient is having recurrent headache and not responding to reassurance, simple painkillers, you may choose SSRI, SNRI or TCA, tricyclic antidepressants. Coming to other important variety of headache is chronic daily headache. When headache is present for more than 15 days in a month for consecutive 3 months, we termed it as chronic daily headache. Chronic daily headache may again be of 2 types, primary and secondary, depending upon presence of red flag symptoms and sign. And what are these red flag symptoms and sign? We will see in coming slides. 2 most common type of primary chronic daily headaches are chronic migraine and chronic tension type headache. So what is chronic migraine? If a patient is having migrainous headache for more than 15 days per month for consecutive 3 months, that is called chronic migraine. And here treatment of choice are topiramate, divalproxodium, or sometimes Botox. What is chronic tension type headache? If a person is having tension type headache for more than 15 days per month for 3 months, usually CTTH is associated with anxiety and depression. So here treatment is usually SSRI, SNRI or TCS. What is trigeminal autonomic cephalgia? It is third important group of primary headache. When patient is having recurrent episodes of headache, and these headaches are associated with some autonomic features like lacrimation, redness of eye, nasal stuffiness, meiosis, sweating over face. These headaches, these primary headaches are termed as trigeminal autonomic cephalgia. Depending upon frequency of attacks and duration of attack, these attacks are divided into 4 categories: cluster headache, paroxysmal hemicrania, hemicrania continua, and last variety is sunct and suna. How to differentiate among these 4 category? Cluster headache usually have 1 to 8 episodes per day. Duration is 15 to 180 minutes. Paroxysmal hemicrania duration is almost 2 to 30 minutes, but episodes may be 4 to 10 per day. In hemicrania continua, headache persists for many days, even for weeks and months. And Sankt and Chuna patient may have almost 100 attacks per day, but duration is very short, usually from few seconds to 10-minute maximum. Some other variety of primary headaches are primary stabbing headache, primary cuff headache, exertional headache, hypnic headache, etc. So other important variety of headache is medication overuse headache. This is very interesting category. These are rebound headaches due to overuse of analgesics or prophylactic medicines. And in our OPDs, almost 25% patients who are referred for intractable headaches actually have medication overuse headache. Coming to secondary headaches. When headache is secondary to some structural pathology in head or outside head or some metabolic abnormality in the body. But in OPD, secondary headache accounts for less than 1%. But in emergency setting, almost 5 to 10% of headaches are secondary headaches. So how to differentiate, how you can differentiate secondary headache from primary headache? For this, there is a mnemonic SNOOP4. This is a very simple mnemonic with which we can easily differentiate secondary headaches from primary headache. What is this? As for systemic symptom, if patient is having history of fever, weight loss, jaw claudication, some underlying systemic disorder like malignancy, coronary artery disease, inflammatory bowel disorder, or history of trauma. So as for systemic symptom, and for neurological symptom or sign, if patient reports double vision, diminution of vision, behavioral or personality change, altered level of consciousness, or any sort of sensory motor deficit. O is for onset. If patient has sudden onset thunderclap headache, or if there is new onset persistent headache, this again becomes a red flag. If age of onset is more than 50 years, if a person more than 50 years present with new onset headache, this is again a red flag. Previous headache history. If a patient of headache has past history of headache, but there is sudden change in character and severity of headache, this again becomes red flag. Then papilloedema, pulsatile tinnitus, postural association, and precipitation by Valsalva maneuver. These all are features of secondary headache. We will see cases of secondary headache one by one with the help of cases. So this is our case number 2. This is 65-year male who is a known case of coronary artery disease and on regular treatment, dual antiplatelets and statins. He presented with headache for last 15 days. This headache was continuous, dull aching. There was no history of fever, nausea or vomiting. But on examination, patient was lethargic and there was slight pronator drift in right upper limb. So in this case, there are multiple red flags. Age is more than 65. Patient have underlying systemic disorder, coronary artery disease, and taking dual antiplatelets. Third is continuous headache for last 15 days. And fourth one is mild weakness in right upper limb. So this is probably a secondary headache. This patient was went for CT and CT was showing acute SDH on left side. So ultimately needed surgery. Next case, 45-year male presented with sudden onset excruciating headache for last 2 days, which was associated with recurrent vomitings. Sudden onset excruciating headache. And on examination, there was mild neck stiffness. Rest of the examination was normal. So in this case, 2 red flags are there. Sudden onset excruciating headache of short duration, and second one is neck stiffness on examination. So CT was done, which showed blood in right sylvian fissure. So this is a case of acute subarachnoid hemorrhage. Fourth case, 48-year female presented with headache for 6 months duration, episodic mild holocranial, no nausea, vomiting, visual symptoms, systemic complaint, but she reports slippage of sleeper from left foot and decreased left hand grip. On examination, there was bilateral disc edema, power on left side by 4/5, and left plantar was upgoing. So here red flags are papilloedema and left-sided weakness. MRI contrast was done, which showed large SOL on right side, right frontoparieto-temporal region. This is high-grade glioma, ultimately needed surgery. Next case, this 40 to 28-year female was admitted in gastro unit for active ulcerative colitis. Call was made for headache. This lady was having headache for last 7 days. This headache was continuous, severe, holocranial. and it was associated with nausea and vomitings. That headache was not responding to routine painkillers. So here two red flags are there: history of active ulcerative colitis, any underlying systemic disorder, and second is new onset continuous headache. So there are two red flags. On examination, fundus showed papilloedema and rest of the neurological examination was normal. MRI was done, which is showing, yes, this subarachnoid bleed in sulcal spaces in right temporal region and ICH in right temporal region. Then CT angio was done with venous phase, which showed thrombosis in right transverse sinus and sigmoid sinus. So here diagnosis was cerebral venous sinus thrombosis, and patient was started on anticoagulation. Next case, this 30-year female presented with headache for last 1 year. She tells intermittent severe holocranial headache, but these headaches are more in early morning while in bed and relieves after assuming upright posture. I have already told that if headache has postural association, this again becomes a red flag. She also tells history about tinnitus and occasional vomitings. On examination, there was disc edema. Rest of the examination was normal. MRI was done, which showed empty sella, tortuous optic nerve, and prominent perioptic sheaths. These are features of raised intracranial pressure. CSF was done, which showed pressure of 350 mm of CSF. So here diagnosis was idiopathic intracranial hypertension. Patient was started on carbonic anhydrase inhibitor. This patient responded very well to carbonic anhydrase inhibitor like Dimox, but in some cases, if patient does not respond to carbonic anhydrase inhibitor, or in severe cases where vision is threatened, we have to go for CSF diversion procedure like VP shunt or LP shunt. This was our next case. 28-year female who delivered by lower segment cesarean section 2 days back for eclampsia. She presented with sudden onset severe headache for last 1 day. Then she had single episode of GTCS followed by altered sensorium. On examination, patient was stuporous. There was no disc edema, but plantars were bilateral upgoing. So in this case, red flags are sudden onset severe headache of short duration. Second is altered sensorium. So immediate MRI was done, which showed edema, white matter edema in bilateral parieto-occipital region. This condition is known as posterior reversible encephalopathy syndrome PRES, and this condition is completely reversible with treatment. Next case, this 40-year female recently married presented with headache of 2 months duration. Headache was daily, continuous with occasional vomitings. There is no history of fever. She was also having low mood, so being treated for depression outside. But on leading questions, she told to have occasional diplopia, and on examination, there was bilateral disc edema. So here red flags are new onset daily headaches. Second, history of double vision, and on examination, there was papilloedema. So MRI contrast was done, which showed multiple ring enhancing lesion in both hemispheres. So here diagnosis was CNS tuberculosis, multiple tuberculomas. So coming to approach of headache, whenever a patient of headache come to your OPD or emergency, you should take detailed history in terms of duration, onset, whether onset was sudden or chronic, gradual, severity, it is mild in severity or severe in intensity, headache is daily or intermittent, is headache has any postural association, does it worsen with upright posture or lying posture, is there any underlying comorbidity, is there any drug history, history of trauma, or any systemic symptom. So history should include all these features, and after taking proper history, there should be meticulous neurological examination to find out any focal neurological deficit, any motor weakness or sensory deficit. You should do fundus examination to look for disc edema, and lastly look for meningeal signs. If patient in history and examination if patient is having any red flag symptom or sign, you should always go for further investigation to rule out secondary headaches. So here I conclude my talk with saying headache is one of the common presenting symptom in OPDs and emergency in each specialty. Almost 1/4 patient in our OPD come for headaches. But good thing is most of the headaches are benign. Secondary headaches account for less than 1% case, but in emergency almost 10% cases are secondary headaches. Exact diagnosis of primary headache is mandatory for proper management. We should always keep in mind the red flag symptoms and signs to rule out the secondary headaches. And every patient of headache needs detailed clinical evaluation. Investigations are based upon our provisional diagnosis. Thank you.